Good evening, everyone. Thank you for attending the sixth webinar in the National Lung Cancer Screening Programme webinar series. We have a double header this evening. We have the first portion on the Structured Clinical Radiology Report and the second half on the National Cancer Screening Register. So to begin, we'd like to do an acknowledgement of country. We would like to respectfully acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land on which the college is located. We acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. We pay our respects to their elders, both past and present. In recognition that we are a binational college, we take this opportunity to acknowledge Maori's Tangata Whanau and Treaty of Waitangi partners in Aotearoa, New Zealand. Together, we restate our shared commitment to advancing Aboriginal, Torres Strait Islander and Maori health and education. So as I said previously, thank you for attending the sixth webinar of the series. Tonight's presentation is a collaboration between the college and Telstra Health. Thank you to the Telstra Health team for agreeing to present on what is gearing up to be a very informative and educational webinar. Tonight's webinar will cover the recently published NLCSP Structured Clinical Radiology Report, which is now available on the now updated RANSCAR webpage and the National Cancer Screening Register. We have some fantastic speakers ready for you this evening. The SCRR presentation will be made by Professor Samantha Ellis, Chair of the ANSTAR NLCSP Template Subcommittee. We will have 10 minutes of questions at the end of the first presentation. This Q&A session will be moderated by Professor Catherine Jones. Dr. Miranda Simenovic, the ANSTAR Chair, will also be available to answer questions at this time. We would also like to advise that all attendees' mics and cameras are currently off. If you have a question, please put it into the question field and we will get to it at the Q&A session. If we run out of time and your question has not been answered, please do not worry. We will forward your questions to the experts post-webinar and we'll get back to you with an answer in the coming days. We are also joined by the Telstra Health team who will present on the National Cancer Screening Register. The Telstra team will present after the first section's Q&A. We will then have another Q&A session for the NCSR presentation. So as you can see, we have a full roster today. We have three college representatives, Professor Samantha Ellis, Professor Catherine Jones, and Dr. Miranda Simenovic, and two Telstra Health reps, Dr. Lev Oros and Mr. Amir Shaverdi. So Professor Samantha Ellis is a specialist radiologist at the Alfred Hospital in Melbourne and the head of the body and thoracic imaging. Her subspecialty interests are thoracic and hepatobiliary imaging. Professor Ellis is on the steering committee for the Australian Interstitial Lung Disease Registry and plays an active role in teaching and research in this specialty area. Samantha is on the executive committee for ANSTAR, the steering committee member of the RANSCAR Lung Cancer Screening Working Group, and lead of the Template and Reporting Subcommittee. Professor Catherine Jones is a subspecialist cardiothoracic radiologist based in Brisbane, Australia. She is the Director of Cardiothoracic Imaging at DetectedX and as well as holding the academic title of Adjunct Professor at the University of Sydney. She is the cardiothoracic lead radiologist at iMed Radiology, which is one of the world's largest radiology networks. She is also a clinical chess lead for AI development at Annalise.ai and sits on multiple governance committees. Dr. Miranda Simenovic is a thoracic radiologist at Northern Imaging Victoria in Melbourne. She is the chair of the Australian and New Zealand Society of Thoracic Radiology and is the clinical lead for the National Lung Cancer Screening Programme on behalf of the Royal Australian and New Zealand College of Radiologists. Dr. Simenovic sits on the NLCSP Expert Advisory Committee and the Data Development Working Group for the Department of Health and Aged Care. Mr. Lev Oros is an integration support and continuous improvement manager specializing in digital health solutions that seamlessly connect healthcare providers, specialists, and participants with the National Cancer Screening Register. And finally, we have Mr. Amir Shaverdi, who is a nuclear medicine technologist by background. Amir's role at NCSR is the lead point of contact for matters specific to radiology integration and stakeholders. He has been working closely with members of the ANSTAR expert community as well as expert committee, as well as public and private radiology providers to help implement the NLCSP. And with that, we will hand you over to Professor Ellis to start the first presentation. So over to you, Samantha.
Thank you, Liam, for that kind introduction. Just give me a moment and I'll get my presentation up. So I'd like to welcome everybody this evening in joining us in the 6th webinar in the National Lung Cancer Screening Program suite of education modules. This is the QR code for the structured report, which is also available, publicly available on the RANSCA website. Just an outline of tonight's webinar. We'll be looking at the benefits of the structured template report, the specific registry requirements. We'll review the guidelines, looking particularly at the fields content table, explanatory notes, unpopulated and populated reports, and we will also walk through an example. So what are the benefits of using a structured report? And we use this in multiple disciplines, but particularly in oncologic imaging. And we know that it promotes consistency, clarity, and completeness in radiological assessments. It enhances multidisciplinary communication, supports clinical decision-making, and improves reproducibility of reports for longitudinal follow-up. And this is particularly important in a cancer screening program such as the lung cancer screening program. It's also more amenable to integration into cancer registries, enabling access to prior reports and contribute to quality assurance activities. The registry has specific data requirements, and we will review the required fields, which are documented in the fields content table in the guidelines. So the structured report is mandated for low-dose CT reports in the program. The fields are mapped to the registry. We will go and have a look through the contents table in some detail, but under the fields titles, there are data values or options that must be adhered to verbatim. So you cannot go left of centre and decide you want a more descriptive term or a different term to put into that space. You must adhere to the guidelines. These fields are also listed as either required, which means they obviously must be filled in, or they're options for some of them to be deleted. And I'll show you what that means in a moment. But essentially, there will be some fields that are not relevant to the specific case you're reporting, and they can be deleted from the final report. We also need to consider that exact wording is needed for data capture. All of the options available are provided in the fields content section of the guideline, and there are also explanatory notes for some of the sections where you may need a little bit more detail before you're able to formulate a satisfactory synoptic report for your use. So what are the sections of the structured report? So we have these subsections: a brief section on clinical notes, study information, nodule findings. This will include specific details to up to 4 nodules in total, additional findings, and then finally the conclusion. This is a snapshot just from a very small portion of the fields content table that I was referring to. And just to briefly look at it, you'll see at the top in blue that I've said some of them have a select option, which means that you'll have a drop-down option and you click on one of those options. And then there are obviously free text options where you can use your own words. So if we look on the top row, for instance, with clinical notes, you see that you can write your own free text, but it is a required field. We move further down to the family history. You've got a drop-down option list here of yes, no, or unknown. And if you'll see in the field use, it says required at baseline only. As we know, the family history is required to use the PanCan calculator, but is not used for follow-up studies. And then down the bottom, second from the bottom, the volumetry software used. Obviously, if you're using that, you use free text to put in your software. However, if you are not using volumetry and using manual caliper measurements, you can delete that line. So if we dive a little deeper into the report itself and we look at the clinical notes, the free text for the history is really just very brief, something, for example, like patient still smoking, eligible for lung cancer screening. The family history of lung cancer, as I said, is only required in the baseline study, and the drop-down options are yes, no, or not known. If we look at the study information, you'll see that some of these will to be pre-populated. So if you are doing the reporting in your practice, you can actually upload and pre-populate some of these fields to improve your efficiency of reporting. And examples might be the radiologist's HIPI number, which I'll go into in a moment, the volumetry used, if you're using the same practice, the same volumetry, and the technique as well, which also will presumably remain the same. Just getting back to the radiologist HIPI number, what is that? It's a unique identifier for each radiologist. I'll come back to that in a moment as to where you can find that HIPI number. Just to not forget the bottom here, two comparison CTs. So you put in the date of the prior CT if there's one available, because for instance, if you're doing a follow-up study, if you're doing a baseline study, it's worth looking in the patient's film bag, for instance, to see if there might have been a previous scan in the last 12 months. And if you think it's an adequate scan, that might be able to become the baseline study. And then the one that you are now looking at will become the follow-up study for that particular participant. If you are using CT scans outside of the screening program, then you need to put those dates in so the next person coming along understands why you've actually started with a follow-up study and where to find that baseline. Now, just getting back to the HIPI number, if you log into the APRA portal and go onto My Dashboard, you will see under your registration details a View All link. If you push that link, it'll come up with all your details, including your registration number, but importantly, your HIPI number. And this is the number that you will need to put into each of your CT reports. Next subheading is the nodule findings. This component of it is quite brief. It's just, is there infection or inflammation, with a drop down, yes, no, a description if there is some inflammation present. Nodules considered benign. Now, benign means something like, for instance, a pulmonary hematoma, or if it's a nodule that's not being used for follow-up. So let's say we've got some sub 4 millimeter calcified granular matter, for instance. You might put those in there and describe those as well. The next line, which says pulmonary nodules for follow-up, is purely a yes-no response. So in other words, are we moving forward in this report to then provide more detail on nodules that are going to be followed up? You'll see also a footnote at the bottom, which should be included in each report, which is explaining that you are only going to be commenting upon a maximum of 4 nodules in each report. And it also states the minimum reportable size of 4 millimetres. If there are more than 4, and you have the unfortunate situation where you do have more than 4, it's up to the radiologist to decide which 4 are considered to be the highest risk nodules, and they are the ones that you'll provide more detail on. And the other nodules will be followed up anyway as that patient is moving forward with their follow-up study. So they won't be forgotten, but they're just not being commented upon in this particular report. If you say no to the infection, you can delete the response below. And the same goes for the nodules considered benign. And I'll be going through and reinforcing this as we go through the reports, because we want to delete lines that are not actually relevant or are left empty because it's not relevant. And we need to delete those so that we've got a very succinct and very readable report. So in this instance, for instance, if you answer no and no, you remove the lines below, and then you say nodule for follow-up, yes, and then we move now into the details of that nodule. So this nodule we've called observed nodule A. As I said, we actually are only commenting on 4 nodules per report, so they will be numbered nodule A, B, C, and D. But when it comes to each individual nodule, they have to be assigned a nodule number, and that's a number 1 to infinity. Each nodule will keep that number with it for the length of the program, so in perpetuity. It won't change. So even if a nodule disappears and it was inflammatory, that will always stay as nodule number 1. Or if it's proven benign through a stepwise progression of follow-ups, it will still retain that number. So any new nodules take on the next nodule number that's available. So it might be 4, might be 5, might be 6. So some patients can probably accrue a significant number of nodules in the lifetime of the program if they're present for 20 years in the program. And you can see then we just really talk about the location of the nodule for the next couple of data inputs. An example here of the type of nodule, and you'll see that you'll have a drop down that will give you one of those options which you will click upon: solid, part solid, non-solid, airway nodule, cyst, or juxtapleural nodule. You may also want to put in some descriptors. You can see the last option there where there's a free text option where you might want to put something like air bronchograms, bubble lucencies, or something else just as a descriptor for the finding. This is where the report can get a little bit busy. The first top left box is really what you'll be looking at if you're looking at a baseline scan. Remember, with baseline scans, we are only using a PanCan calculator, unless, of course, it's an endobronchial nodule or an atypical pulmonary cyst. So we need that maximum axial diameter with free text. We assign a PanCan risk and then assign a screening category to that nodule. I'm highlighting these boxes here because even though we don't look at volumes or we don't look at mean diameters in the baseline study, it's prudent to actually put these measurements in. And the reason being that this person is going to come back for a follow-up study at some point in time, and another radiologist may be looking at the scan. When they're looking at that scan, they're not interested in the maximum axial diameter anymore because it's no longer baseline and we're not using the PanCan calculator. And that's when we move forward to looking at volumes or at mean diameter measurements. So if you can pre-fill those in, that will make it much easier and facilitate comparison for the next radiologist looking at this particular nodule. Many volumetry softwares will automatically put all of those figures into a report for you, and you can translate those numbers into your own report. The next, oh, sorry, I went a little bit too fast there. The bottom right box, you can see there's a lot more detail, and that's what happens when we start moving into the follow-up phase of a nodule. So you're looking at, for instance, if you're using volumetry, for instance, the top two sort of small paragraphs will be relevant to you, where you're looking at the volume, the percent change and the volume doubling time, or if it's a part solid nodule, you'll also have to do the same for the solid component. If you are, however, not using volumetry and you're using caliper measurements, then you're interested in the mean diameters. And that's where the next two paragraphs fall in. And this is why it's important to delete any data that is not relevant to your report and to clean it up. So you don't want all those volume measurements above yours if you're doing mean diameters. So most of the lines actually will be able to be deleted. Don't forget that an atypical pulmonary cyst has its own little paragraph at the bottom because we don't use volumetry software for cysts. And then lastly, at the bottom, you put the type of change, that is whether it's stable, slowly growing, growing, or reduced in size, and the screening category assigned to the nodule. Moving along then to additional findings, and this is where obviously the additional findings guidelines come to the fore. You answer yes or no to whether there are actionable additional findings in this study. If you answer yes and you found something in the lungs and you've answered yes, then all of the rest may be not applicable and they can be deleted. You also put a free text option of what that finding in the lungs is, and you refer then to the additional findings guidelines, and you use the words that have been placed in the guidelines verbatim. So if you see emphysema, you write what the national guidelines recommend as your text for that finding. The recommendation for the follow-up comes in the conclusion. You don't put that here. This is just the description. In this case, you might say that there's emphysema, which I imagine will be quite a common finding in this patient cohort, and you decide whether it's mild, moderate, or severe, and that's what you place in your report. Then we move to the conclusion with the screening category and management, and you select from a drop-down box from category 0 through to category 6. You may wish to put a nodule summary in, particularly if some nodules have actually resolved and they may well have been inflammatory. And then finally, the actionable additional findings summary. And this is where you put the free text with the recommendation as per the guidelines. And as you can see there, with all the various severities of emphysema, it says clinical review, refer to Lung Foundation Australia Handbook. So let's run through an example so we can actually see what so it's a lot to take on board when you're really just looking at words on a slide. So this is a patient who's presented, it's their first baseline scan as part of the screening program, and we see this atypical pulmonary cyst in the right upper lobe. You can see it's septated, it's got thick, slightly nodular, fuzzy margins with some ground glass surrounding it. You've also noted on the soft tissue windows that there is contiguous, thick, calcified coronary plaque and a moderate-sized pericardial effusion. So we move into the nodule findings component of the report, and this is where we really answer some very quick questions on: was there any infection in the study? No. Were there any nodules considered benign apart from the one we're actually looking at? No. And were there nodules for follow-up? Yes, there's this atypical pulmonary cyst. And you can see again the footnote explaining that we will report up to 4 nodules and with the minimum size criteria listed. Then the details of that nodule. We've assigned it a nodule number. In this case, it's nodule 1, the date it was visible, where it's located, and the type of nodule, in this case, an atypical pulmonary cyst. It's prudent with cysts to actually write a description of the cyst because they don't necessarily grow in size and size alone like solid nodules. They can just change in morphology. So it's important to put for the next reporter what you actually found. And so in this case, you'll say multiloculated with an asymmetrically thickened wall with some adjacent ground glass opacity. Now this is where it gets a little bit busy, but of course this is just the baseline scan, which makes it much simpler. We can also erase the PanCan calculation with the % risk because this is an atypical pulmonary cyst and we don't use the PanCan calculator. Similarly, we don't use volume measurements. So we're using the mean plane or mean diameter of the cyst in the axial plane. We've put a measurement of 25.3 millimeters with a wall thickness of 3 millimeters. And finally, this is a screening category 4. So if you clean it up at the end of the report and take out all the data fields that you don't need, you've got a very succinct and efficient and easy to read report. Moving to the additional findings, we've decided in this case, yes, there are 2 findings. They come under the cardiovascular heading. We describe them here: severe calcified atherosclerotic plaque, and this is the words used verbatim from the guidelines, and also a moderate pericardial effusion. All of the other fields are not applicable. And finally, the conclusion. You've assigned it a category 4, 3-month low-dose CT. We list the actionable additional findings with their recommendations. In this case, clinical review for the coronary plaque and recommend lifestyle modification and pharmacological therapy, and with the pericardial effusion, clinical review and refer for echocardiography. Very important that the footnote here is also placed on the bottom of every report. And this is to facilitate image comparison. So we're asking the participant to please return to the same imaging provider for future studies to facilitate comparison, because otherwise it's our job or our clerical staff's job to go and source that imaging and try and find it and bring it into our own packs so then we can do a comparison study. So we're recommending to please try and come back to the same provider. So let's revisit this nodule now when it's come back 3 months later. And how do we look at the report now? Well, we can see that this has actually lost its sort of fuzziness. The wall is now thin. It still has a thin internal septation, but it looks improved. So what happens with this nodule? Well, it came in at a category 4, which was recommended a 3-month CT. And you can see now that it has de-escalated to a 6-month low-dose CT or a category 3 nodule. And if you read the text, a previous category 4 lesion that is stable or decreased in size. So the report now, we again measure it in the mean diameter in the axial plane. On this occasion, it's 22.5 millimeters. The wall thickness is now 1. Previous measurements here, very helpful because it enables you to see quite clearly that this is decreased in size. It was previously 25.3 with a 3.3 millimeter wall thickness. So the type of change, which again is a drop-down option, is decreased, and the screening category is now category 3. We also happen to notice the pericardial effusion had resolved, but the plaque was still unchanged. So the conclusion for this patient now is a category 3, 6-month low-dose CD. We only comment on the actionable finding, which is the severe coronary artery calcified plaque. We have to reiterate this recommendation because we don't know that the GP or the referrer has actually actioned this finding. And the same footnote about returning to the same imaging provider. And I've just placed a report just to show what likely the vast majority of reports are going to look like. So we envisage that at least 70% of patients walking in the door for their screen will actually go to just run back to a normal biennial or 2-year screen. So they'll have a normal CT. And this is how the report looks when you actually remove all of the other data fields, assuming that they're allowable fields, of course, as well, because I've said that there are some that are required for the registry. But if they're able to be removed, you can really clean up the report and make it much more succinct and very readable. And in this case, you can see the clinical notes are short and brief. The family history, yes, you've got the study information there. Some of those fields which you can pre-populate. The nodule findings in this case is no, and there's no follow-up nodules. No actionable findings. And then the conclusion, very succinct, screening category and management is category 1, 24-month CT with again, the footnote about returning to the same imaging provider. So very nice and very succinct. Just before I finish, a couple of tips and tricks to consider when you're setting up the template in your own RIS is that you need to work closely with your PACS and your IT team to create a structured template to report in your RIS. Pre-populate certain fields to improve efficiency of reporting. As I've sort of reiterated many times, fields that may be deleted should be removed from the final report. Now, some of these may be automatically deleted. If you have where data fields left unpopulated will be automatically deleted, that will save you a few steps. But many will require a manual delete once the report is actually completed. I also urge you to print a sample report to ensure that your report layout that is going to the referrer is as expected. And I've sort of, over the years, have created a number of templates for various imaging conditions in our RIS. And I always thought that they were going out to the referrer as I saw them and as I filled them in on our RIS. And I found one day when I saw it back in the patient's history, and it looked terrible. It was just a whole mishmash of lines. There was no spaces between paragraphing. There was no bold type, which I tried to do, for instance, some of the headings in a bold type so they stood out. So I urge you to actually print one out just to see, because then you might need to go back to your PACS team and to see if you can actually troubleshoot so you've got a better report that reads cleaner. And last, I thought it'd just be worth touching on aging out. So a participant, we know the eligibility criteria is 50 to 70 years. That actually takes them out to 70 years and 364 days. So if you happen to note that a patient is nearing the end of the eligibility for the program and they have a nodule that it's still requiring follow-up, or they've got an actionable finding, that it's worth putting in the other comment section, which is in the conclusion of the report, and put a line such as all further follow-up and management of nodules or additional findings will occur outside of the National Lung Cancer Screening Program at the discretion of the referrer. And that's just so these patients don't get forgotten. So thank you very much for attending tonight's webinar. I'd like to extend my thanks to the reporting template subcommittee members for their work in helping bring this template together, and of course to my colleagues on the steering committee. I will now leave the floor open for questions. Thank you.
Thank you very much, Professor Ellis. That was a really great run through of what is a very complex topic, and I'm sure that many of us will be watching this webinar back multiple times into the future. And welcome, Miranda, as well. I do have some questions that have come through, so most of these will be directly to you, Sam, but Miranda, of course, please do jump in if you have some thoughts as well. First question is, how do we deal with cases where there may be one or more nodules which are baseline because we have no follow-up, but one or more nodules which are follow-up protocol because we have a previous CT abdomen, for example? Can we mix and match from the master template into the final report?
So if I'm understanding this correctly, you've got some nodules that are you've got a couple of nodules that have been picked up on a baseline, and they have been assessed using the PanCan calculator and are being followed up accordingly. When you do the follow-up, you've then got new nodules that have come into the
Actually, I
new
might say it
nodules that
again
have
because I
appeared.
realised this was nowhere
Is
near
that what
my
you mean?
face. Not really.
Ah,
No, sorry. I'll try again. Clearly, I needed to
because
have this near my mouth. The question is, how do we deal with cases which the first screening case for that patient,
yeah.
but there's at least one nodule which is baseline because we have no previous to compare with. But say, for example, a lung-based nodule where we can have a
Oh,
follow-up.
okay.
So we've got a previous abdomen CT. Can we mix and match from the same master template to create like a hybrid version of partially baseline and
Yes,
partially follow-up for the same case? So
you
the answer, I
can
think, would be
because
yes. Yeah.
yeah, yes, you can. So if you've captured, as you say, on the bottom of the lungs on a CT abdo-pelvis, that nodule was present 12 months ago and is stable. And then you do the current study, the full chest, and you find new nodules. Then the first nodule that you have seen on the abdo scan, that will be treated as a follow-up. The other nodules that were not seen are put through the PanCan risk calculator. So yes, you can mix and match.
Yep.
I've said that
And
correctly.
obviously, yeah, mix and match. And obviously, when that
Yeah,
participant comes back for a subsequent, then they were all considered follow-up
all follow up.
anyway.
Yeah,
So
that's
this
right.
would only ever occur for the very first
Yeah,
screening CT.
yeah.
Um, the next question that we have is, what should we do if the CT is mistakenly reported as a regular style report? So, it's picked up by mistake by someone who's unaware of the requirements. What should we do if we just report it like a regular CT? Should we go back and
I,
re-report it, do an addendum? My
Well,
feelings,
it needs
yes.
to go. It needs to go to the registry. Yes, absolutely. So if someone's mistakenly done it, it's just gone into the routine reporting pile and then into the patient's film bag and the EMR, then it has to be pulled back out again and has to be re-reported because it won't get sent to the registry. The referrer will not be sent the recommendation if there is well, there will be a recommendation. So it does need to be re-reported. Yes. So hopefully someone will flag that because we will not know necessarily unless I guess the referrer gets back to us and says, listen, I haven't seen a report. And that's probably how it would be flagged to us. And yes, we would have to go back and re-report.
Mm-hmm. And I'm sure Telstra Health will say as well, but they may flag that they haven't received the report either.
Yeah.
Um, Now, this question you probably already answered. Is it a problem to leave the fields in the report if they're not mandatory fields, but to leave them empty? I think we agree that it's more readable and it's
Yeah.
much nicer
Yeah.
looking report to delete them, but do
Yeah.
we have to delete them?
You don't have to, but there are a lot of data fields, and particularly
Mm,
with all the different types of measurements. I think if you leave it in there, I think you will lose the data that's important. So, and for the next
hmm
radiologist, if you think of the next person coming along, they won't have to sift through that either. So, I really would heavily emphasise you get rid of any data that's not required.
Yep, I would agree with that. And we have another question. If we're using voice recognition templates, would you recommend using pick lists or drop-down menus for the fields that are the drop-down options? I've got a thought on that, but I'll see what Sam and Miranda say.
Well, I've only ever used drop-down menus, so I don't have any fancy voice recognition software that can do anything more fancy than that. So I might have to leave you to answer that because I don't have the experience, I have to say.
Miranda, did you want to have any comments on that?
I would just say that if you have the functionality in your speech recognition software for drop-down menus, that's what we should be using to have all of these options specifically verbatim saved into your software already, that when we reach for that field and need to fill it out, we're reliably using the absolute correct language. So whatever that looks like on your platform, whatever functionality that is, whether that's a mouse click or a voice command, that's how we should be making sure that we populate the exact language for those specific fields that need it.
Mm, I agree. And obviously, there's a variety of commercial products out there for voice recognition. Some of them are standalone and some of them are embedded into the RIS. Some of them have the option of doing pick lists, which is essentially a way of saying a drop-down menu, pick the best one of the following. But if you don't have that option, you might have an option of using macros, for example, where, as Miranda has pointed out, it has to be verbatim. And I certainly wouldn't want to be sitting there manually typing it out or saying it and hoping that it gets it right. I'd be using as much automation as possible, using either those pick lists or those macros to make it as easy as possible. Now, there's another question that's come through from one of the attendees saying, is there a requirement to add in a bone density measurement in the lumbar spine? And if so, is that a space in the structured report as well?
It is. I didn't actually put everything up for the additional findings. I mean, that was gone through in some detail, I guess, in the additional findings webinar. But yes, it is recommended that you do look at and do a L1 bone density measurement, and then report it if it's abnormal. And what is considered abnormal is detailed in those guidelines. I think the one thing to say is that we are not used to reporting probably what are the most important additional findings in our routine CT chest reporting. And one of those is bone density, the others is coronary artery plaque and aortic valvular calcification. We're not used to reporting them, but they're the ones that will have the biggest impact on the patient. So I would say yes to that.
Yep. I think just to elaborate on that question, I wonder if the question is also related to whether you need to record the specific Hounsfield unit measurement for a normal measurement. And I would say no, that that filling that out, the subcategory, the body system is bone. And if that is NA, not applicable, nothing to see here, because when you measured the bone density at L1, it was 150 Hounsfield units. No, I would not say that you need to specify that it was normal at 150. Delete the field, move on is absolutely fine, or leave it present bone NA and move on.
Yep.
Fantastic. And there was a couple of questions that came through saying, how do we find out more information? I think Sam's definitely answered that, but as well, we'll be able to go back to the college website where all of these resources are available. Another question has come through. If you realize you've made an error, can you retrieve the report? So presumably after it's been sent off to the registry, can you retrieve the report and amend it? I'm wondering if maybe that's a question that we can leave for our colleagues at Telstra Health about how they could, talk around that question. And you can certainly do an addendum in your RIS. Yeah.
But I know that the capacity exists for discrepancies to be managed in the NCSR. So absolutely, if we could make a note for the Telstra Health team to elaborate on the processes that will be in place around that.
Fantastic. Well, I think our 10 minutes is up for the Q&A. I would like to say thank you very much, Professor Ellis. That was a really good run through of a very complicated topic. So thank you very much. The examples you gave were fantastic. And as always, thank you, Miranda, for your leadership and guidance in this space. And just to say again, that structured template report subcommittee has been working around the clock for well over a year on this topic. So thank you very much to everybody in that subcommittee for all of the hard work that you've put in. And we'll hand back to, sorry, go ahead, Miranda.
Just before we hand over, I will say that as Sam has gone through, of course, the structured clinical radiology report guidelines are now available off that QR code that was shown, but they're on the NLCSP website. The additional findings webinar link is under the radiologist resources as well. But what is also there, which is absolutely hot off the press, is the link to get into the e-modules that cover all of the workings of the program now. So all of those e-modules are live. The link is on the RANZCAR NLCSP website. It takes you through to the RANZCAR login page, and when you navigate through that, login as your under your membership profile, you click into the e-modules that step by step through take you through all of the elements of reporting for the program. So that's now the nodule management protocol, interpretation of nodules, the additional findings, the background of the program, anything that you want to deep dive into further. If you've been to one of the workshops, you might still have lingering questions or want to consolidate your knowledge, or if you didn't have an opportunity in the live workshops, these resources exist now as a self-contained start to finish process of understanding all of the elements that you will interface with in the NLCSP.
Thank you very much. That's a great point as well. Right, we might wrap up the Q&A, and I'll hand it back to Liam for the next part of the webinar. Thank you.
Great. Thank you all so much. That was a great presentation. Sam, great, thank you. And thanks to Miranda and Catherine for hosting the Q&A section. So with that, I will hand over to the Telstra Health team, who will be presenting on the NCSR for the next 10 to 15 minutes. And I'll hand you over to Amir. Over to you, Amir.
Thank you, Liam. I'm not sharing the correct screen. Just bear with me a moment, please. Excellent. Thanks, everyone. Thank you very much for your time this evening. I'm just going to share my screen. Hopefully, everybody can see it. Now, we're just talking about the National Cancer Screening Register this evening. And we're just going to give you an overview of how the NCSL will support the new National Lung Cancer Screening Program, the NLCSP. Now, a National Cancer Screening Register, or NCSR, is a digital platform that was established almost 8 years ago or so, and it actually presently supports the National Cervical Screening Program, as well as the National Bowel Cancer Screening Program. Now, 1st of July, it will also support the National Lung Cancer Screening Program. The NCSR is enabled by the NCSR legislation, and NCSR is actually more than just a registry. It supports all the operations of these screening programs to maximize participation and facilitate timely diagnosis. Now, this slide provides you a little bit of a pictorial of how the NCSR supports the National Lung Cancer Screening Program. Starting from the GPs assess the potential participants, and we call them participants and not patients because they're not patients yet, and they refer the eligible participants for a low-dose CT. Now, at the same time, GPs also submit the healthcare provider or HCP eligibility and enrollment form, either through the clinical information system, so they would have their clinical information system integrated with the NCSR, or directly into the healthcare provider portal, which is a portal supported by the NCSR. As we all know, the radiologists will conduct an assessment using the National Lung Cancer Screening Nodule Management Protocol, and then submit a structured report and overall recommendation to the referring GP and NCSR. Dr. Ellis just obviously went through all that. If a patient has been referred to for a low-dose CT, and this is where NCSR comes in. If a patient has been referred for a low-dose CT, but the NCSR hasn't received their scan reports and the MBS items haven't actually been claimed, then the participants will receive a reminder from the NCSR to make sure they go ahead and book their appointments for the low-dose CT. Now, in cases where a participant is at a high risk of lung cancer based on the low-dose CT scan results, they will be referred to a specialist. And the specialist will determine, obviously, the diagnostic pathway, which may include a biopsy or other processes. Again, the NCSR at this point will advise the participant to follow up with their medical practitioner, and also the NCSR will notify the health provider of the results. So again, there's interaction on all levels from the NCSR. Now, if the participant has a cancer diagnosis, the specialist or GP then submits the diagnosis form to the NCSR. Now, this can be done again through the integration with the NCSR or through the HCP portal. Again, at this stage, the NCSR will remind the participants at this stage, patients, to go back, follow up with their doctors, and also the medical healthcare providers will receive a copy of the results. Now, any histopathology reports will be transmitted automatically from integrated labs to the NCSR to support the program for reporting. The cadence of the reminders to participants was determined by a clinical expert panel comprised of radiologists, specialists, and GPs at the time of designing this program. So all this has been really well thought through. Now, once the program begins from July, radiology providers will be mandated, as we all know, to send a copy of the final screening reports to the NCSR. Now, this mandatory report must be submitted as soon as possible, as it plays a pretty critical role, obviously, as we know, in determining the next steps in the participant screening journey. So whether they need to have rescreen or even might even leave the must exit the program. Now, screening reports can be sent to the NCSR via the integrated software at HL7, which is really the recommended way of doing it, which makes life a lot easier for everyone, or through the healthcare provider portal. Both of these methodologies are ongoing options for the radiology providers. For the first 6 months, though, there is a transition period. And during this time, their practices are allowed to, who don't have an integration yet, are then allowed to actually submit reports manually. And this is through either fax or post. Now, this is obviously from 1 July to 31st of December 2025. After this period, any manual reporting will no longer be supported. So please, I'd like to remind you of that. So HL7 integration. This is the best way of sending the results to the NCSR. And really, I want to highlight 2 documents that are central to integrating radiology information systems with the NCSR. Now, the radiology implementation guide has been developed to inform radiology providers of the process that they need to follow to be able to integrate their systems. This guide was developed through consultation with radiology providers, as well as a lot of the major RIS vendors. And it is really a technical document that's going to help the IT personnel to develop the electronic integration components and to be able to link to the NCSR and send the reports. And of course, the other document is the structured clinical report, radiology report, which Professor Ellis has already been through. I think the most important thing for me to mention here is that any template set up in your radiology information system must follow the prescribed format in this document. So please do not deviate from this document, as this is pretty much the Bible for setting up the integration. Now, I've already mentioned that the Healthcare Provider Portal, or the HCP portal, is available on an ongoing basis. So basically, this platform can be used by radiology providers to submit reports. The requirement is that the clinical report can be entered into the report form, which is provided on this platform, but this is going to be a manual way of doing it. Now, here we've included some screenshots of the healthcare provider portal to show you what it actually looks like. Now, again, please note that the look and feel of the HCP portal won't be the same as your integrated software. So you're not going to see a lot of these fields in your integrated software because they're actually automatically filled. So again, you need to understand that also the point is that the radiologists need to register as users to use this platform. Now, they can have delegates also registered who can then act on their behalf. My colleague Lev will provide some further details on this a little bit later in this presentation. The screenshot also demonstrates the page where the search can be done for the actual participants. Obviously the various search fields are there and they need to be filled, and the participant will then be found. If the participant is found, and if the participant is actually already enrolled in the lung program, then you will see a lung active program, an active word next to the lung. And that means that that person is already enrolled and the report is ready to be put in. However, there are going to be cases that the lung program will not be showing as active. And in this case, NCSR can be contacted so that the participants can be enrolled by the NCSR staff. So once the participant has been found and are enrolled in the program, the National Lung Cancer Screening Program Registry data set will then be available for the various bits of information to be put into, including the clinical report. Again, I want to highlight that at a minimum, all required fields must be filled before the report can be submitted. Now, the required field are those mandatory fields that Dr. Ellis has already referred to as well. But in this form, there are going to be a few more for there, because a lot of the demographic information will also need to be put into this form. These are the bits of information that in an HL7 integration situation would have already been filled up automatically in the form. Now, again, note that in cases where a practice has full HL7 integration with NCSR, all details relating to the participant, referring provider, reporting radiology practice, and the radiologist will be automatically sent to NCSR. And there is no requirement from the radiologist or support staff to actually have to put that information in. So this is, I just want to make sure that everybody understands this. HL7 integration will not require you put that information in as reporting radiologist or support staff. The LDCT report part of the form will be obviously very familiar. You've seen parts of it in the previous presentation, but again, I wanted to highlight the mandatory fields that are, again, will be automatically filled if there's an integration. And again, the required fields that are important for making sure that these are accepted by the National Cancer Screening Register. Now, the temporary manual reporting form is going to be available for 6 months. During this time, the LDCT reports can be sent via fax or mail to the NCSR for manual entry. Now, the clinical component of the report must adhere to already published report template, which we've already shown the document for. Now, at a minimum, when you're submitting a manual report, there are 25 fields that are required by NCSR. These include demographic and clinical information fields. So these are the fields that would have been sent automatically by if you've got an HL7 integration, but these now have to be put in manually. And the reason they're required is so that we can actually match those participants against the right records in the system. Now, on the right, you can see a screenshot of one of the quick start guides that has been created by NCSR. Now, these documents with other training resources will help support you in the lung program. So, and these will be available from the NCSR website from the 1st of July. Now, I have reached the end of my bit of the presentation. I'm going to stop sharing my screen, and I will pass over to my colleague, Lev, to do his bit. Thank you.
Thank you, Mia. With the last few minutes we have remaining, I'm going to quickly take you through the one-time registration experience that you're going to need to go through to register for either the healthcare provider portal or as a delegate. And also if you're going to use the RIS integration, which will allow direct RIS to NCSR into integration. And I'll also share some of the resources that are available to help you through this as well. So the first screen that you're going to see at the moment should be PRODA. So you will access the healthcare provider portal via PRODA. So you'll log in as you would normally, including your 2FA. And the very first time you click on the NCSR tile within the PRODA, you'll get presented with the option of linking your account. As a healthcare provider that has a Medicare provider number, I'm going to choose I have a Medicare provider number. and click continue. I'm going to choose that I'm a general practitioner or other specialist. And then I'm going to enter my provider number. I'm going to save that. You do have the ability of adding additional provider numbers if you do have them here. And click link. That will complete the registration step. So simply those 3 steps of logging in and adding your provider number will give you access to the registration. The next step will be to allow your delegations to have access to it. So I'll quickly show you that. So here we have Emily. She's going to log into the NCSR through the tile again. And instead of choosing I have a Medicare provider number, they're going to choose I'm a practice lab staff acting on behalf of the healthcare provider. Now, it's really important to note that the provider number that they're going to enter in on this screen will already have to be an existing healthcare provider portal user. If they don't, they'll receive an error message saying that they're unable to link. So upon entering the provider number that they're going to request delegation from, they're going to click Save, and they're going to choose Request here. And they're going to see that their request access has been sent to the healthcare provider. Now, the healthcare provider themselves will log back into their healthcare provider portal, as you can see here. They're going to go into My Profile, choose Manage Delegation, and either approve or reject the delegation request, after which Emily here will have access to the healthcare provider portal themselves. Now, finally, and the most preferred way is the RIS integration. So, to complete the RIS integration, there's a couple of steps that need to be done within PRODA before we can start our registration. Within PRODA, the responsible officer will have to navigate to the organisation within PRODA, click on the organisation name, and we'll have to add NCSR as a service provider into the service provider list to the organisation. Once the service provider has been added, we need to make sure that the person completing the registration is authorised to do so to accept the terms and conditions by clicking Members, choosing the person who's going to complete the registration in the list, choosing Attribute Delegations, and delegate to this member the NCSR CIS terms and conditions, and delegate. Now that we have those prerequisites in place, we can commence the registration process. So we'll click on Services to see the NCSR tile, choose the NCSR tile, start the process, choose the organisation I'm going to act on behalf of, and at the linking screen, we're going to choose I would like to register my radiology practice using HPIO. I'm going to enter my HPIO, and this is the HPIO that's used within the RIS software itself. Again, if I have multiple, I can add additional multiple HPIOs here. And I'm going to enter all the details that are required to complete registration, including organisation name. I'm going to enter the ABN, and this is the same ABN that is in the organisation within PRODA. Enter all my address details. Enter the number of sites, number of clinical users, administrative users, what sort of service I have. So here we can see we have radiology practice and the software that we're using, which is the RIS. And I'm going to complete all the details for the responsible officer, the technical lead, if there's anyone, an alternate contact, represent that I am acting on behalf of the responsible officer, and then registering. You'll be presented with the terms and conditions which you'll accept, and you'll see HPIO registered. At this point, the registration is complete. And at this point, I will pass back to James. Oh, sorry, Liam. Back to you, Liam.
Hi, thanks very much to the Telstra Health team. That was great, very informative. I think we have enough time for a couple of questions from the audience. I think we have one assigned here to Peter Collins. If you realise you've made an error, can one retrieve the report and amend?
Yes, that is absolutely true. So you can do that. If you do it through the basically you just have to send a corrected report, which is the full report with the result status indicator marked as corrected as opposed to final, and the area that has changed as corrected as well. What that will do is it will advise our system that there's something has come through that needs correction, and it will then do a soft delete of the existing report and then rewrite it to the database.
Okay, great. Thank you, Peter. Amir, we have a question for you. If we generate a structured report for a first-time attendee and submit to the NCSR, but then discover a complete chest or partial abdominal CT, for example, prior imaging from outside of the program, are we able to regenerate and submit a new structured report? And if so, will this override the previous one, or will the original structured report still be retained?
Well, I suspect this would probably be just an amendment to the original report if you found previous reports and you wanted to add something to it. So it would basically be what Peter just explained. So it will be an amendment of the original report.
Okay, that is great. And then another question for you. Who would be considered a responsible officer?
I'll take that one. So the responsible officer is typically who owns the ABN and who's actually added the organisation into PRODA. However, what they can do, they can delegate the responsibility of responsible officer using that members component within PRODA and adding the SIS terms and conditions to that person to accept. So anyone who has that attribute within a PRODA organisation will be able to act on behalf of the responsible officer.
Okay, great. Thank you, Lev. A question for Amir. What is the pathway if a specialist would like to refer a patient for lung cancer screening?
Yeah, this is definitely an Anna question, and she couldn't get onto this, but that's okay. So basically, it is exactly the same. The participant will still need to be enrolled into the program, and there is always going to have to be a GP that's going to manage the participant. So there will have to be a GP name or details that would be provided, but a participant can be referred to the program by any medical practitioner.
Okay, great. Thank you, Amir. So does anybody else have any further questions? You'll just check the chat.
Miranda would
Okay.
probably want to add to that.
Yes, Miranda, work away.
Yes.
I actually just wanted to touch on the general presentation from Amir, and thank you so much for taking us through all of the different opportunities that exist to input that data into the NCSR. And for anybody who might have questions about where the healthcare provider portal sits in your routine workflow, we've seen how it interfaces with a number of different people in a radiology practice. So we've talked about the HPIO registration and the ABN owner who will hop on and do that practice registration. We've looked at radiologists registering in the healthcare provider portal, which I did, and it took about 15 seconds. Lev's right. It's really, really simple. The function for me to do that is, as my local champion for lung cancer screening, I am the provider number that my front desk staff can be delegated through. So I did that. It took me 15 seconds. And then every time one of the front desk staff registers themselves as a delegate, they'll flick me that notification, which I'll approve. The front desk will be logging onto the healthcare provider portal to download 3 documents for the radiologists. They'll be looking at any prior NLCSP reports and bringing them down, loading them into the RIS for you. So once participants are coming back for future reports, they'll be putting that into the RIS. That should be part of the workflow. They'll also be looking for the any diagnosis forms that exist in the NCSR for anybody who's had a previous high or very high risk finding. A diagnosis form will then exist in the NCSR to take the radiologist through the outcomes of what further workup actually resulted in. So front desk will be pulling that down if it exists for the participant. They'll also be pulling down the nodule history report, which is a per nodule map of everything that was submitted by radiologists for that participant around any of their findings registered historically in the NCSR. So once we start seeing these participants come back over and over and over with multiple findings, there will be data that's being built up using that assigned nodule number, so that every nodule that's registered in the NCSR has its own little history that gets tabulated out, that the radiologist will be able to look at for an at-a-glance view of what all of the previous measurements were. Of course, that doesn't replace our visual review of previous studies, but it's just another powerful tool that we synthesize into our interpretation of those findings. So when front desk hop on as a delegate, those are the 3 documents that they're looking for per participant once they come for their scan to support us in our interpretation. And just to clarify what Emir showed up on the screen with the different fields from the structured clinical radiology report as they exist on the healthcare provider portal, I would not be surprised if that interface that you saw when you log into the healthcare provider portal and those fillable fields exist there, I would not be surprised if that is never used around the country, because what we're expecting is radiologists to be simply using their routine everyday workflow, business as usual method for generating these reports through speech recognition, through typist, whatever it is you use, according to the format of the structured clinical radiology report. For 6 months, you can fax that into the NCSR with the peripheral fields that are still required in the background about the participant and their address and all that. And then moving towards electronic integration, where that's going to happen electronically in the back end without you doing anything. So for completeness, there certainly exists those fields in the healthcare provider portal, but I expect that the 15 seconds that I took to log in so that my front desk can use me to be delegates is the be all and end all of my interaction with the healthcare provider portal. So just to clarify what we expect to be the day-to-day interactions of radiologists as we navigate this program.
Great, thank you very much for that, Miranda. And I think we have a final question for Lev. You mentioned PRODA, and someone just wants to know where will they find the registration for that.
Perfect. So PRODA is available. If you just Google PRODA, it'll come up, and the web address is proda.humanservices.gov.au. But I direct you to ncsr.gov.au, and there's a whole section called Healthcare Provider and Access, and that'll take you through all the instructions that I've showed you tonight, including all the PRODA links, as well as a callback link if you want us to give you a call back and handhold you through the process.
Great. Thank you so much for that, Lev. I think that'll be the end of our question and answers session for tonight. We just have one final section, just an update from the college on a few of the activities and resources we've been working on. So just bear with us while I share my screen. Okay, hopefully you can all see that screen. So the first thing is, if we would encourage anybody who's interested in the subjects discussed today to please consider joining ANSTER. It's open to all RANSCAR fellows and it's free, it's fun. You'll get regular newsletter updates specifically about the NLCSP. There is a QR code to join, or you can click on the link below there. The next thing is we still have a few workshops up and coming. You can sign up to them.
Sorry, Liam, to butt in. I mean, we can't see your screen, but I'm going to share mine, and then people will be able to see that QR code. Just one moment.
Okay.
Okay, can you see that?
Bear with me. Yes, we can see that. Yeah. So there is the Answer QR code. Please just take a scan of that, and you will be able to follow the instructions, and we will sign you up for Answer. They do nearly monthly newsletters and a lot of updates on the NLCSP. So can we move on to the next slide? The next one is about the NLCSP workshops. We basically have run 4 over the last couple of months. We are running another run in Hobart, and we are going to be running a few of them at the ASM as well. Please click on that link. That'll take you to the recently updated NLCSP webpage, and on that you can find the registration link. So the next slide, please. And this is just a quick image of the last workshop that we ran down in Melbourne. We had our largest turnout. The feedback was fantastic and it went really, really well. So if you are down in Tasmania around June 22nd, please register and we'd love to see you there. So the next slide, please. As Miranda had said earlier, Ransker are delighted to announce the launch of the NLCSP education modules. The modules are a self-contained, self-paced suite of materials that are presented in an approachable, tailored package that will take any radiologist through all of the detail needed to report confidently for the NLCSP. The modules are hosted on the DetectedX education platform. They're now available via the My Ransker portal. To access, log into your My Ransker profile, select the blue Learning Modules tab and scroll down to find the e-modules. Then click on the DetectedX button to register and sign in. There are an additional 2 modules that are currently in the works and will be made available in the coming weeks. We have also included a survey in this series. We would ask that users fill out this survey after interacting with the modules, as the feedback will be reviewed and used to improve the modules on the run-up to and post-launch of the program on 1st of July 2025. There's further information on how to claim CPD and how to register with DetectedX, and they can be found on the My Ransker portal. So the final slide, the next slide, please. And the probably most important one, the CPD points. For Ransker members, CPD points for attending this webinar live will be uploaded to your individual CPD profiles by the Ransker team over the next few weeks. You do not need to do anything to claim CPD hours. We have had a few emails from members asking about when it will be uploaded, and we're currently working on it. Apologies about the delay, and thank you for your continued patience on the matter. For non-Ransker members, a certificate will be distributed to each member as proof of attendance to the webinars, and then certificates will be distributed over the next few weeks as well. Again, a survey will be emailed out to all participants who consented in the initial registration form, and we'd really appreciate it if you give your feedback about the webinars. And then a final closing statement. We'll be organising another webinar in the series in the coming weeks and months, and we'll promote the event via College Channel when a subject, date and time have been confirmed. And finally, we'd like to thank all of our presenters for a very informative webinar. Thank you to all attendees for taking the time out of your busy schedules to participate in the webinar, and the recording will be uploaded to the NLCSP website. We've recently upgraded it, so please check that out over the next few days. And thank you all and have a great evening. Bye now.